our masterclass, OSCE masterclass sessions. I'm Yurisa. I'm a clinical fellow at the moment, and I previously worked in emergency medicine. And I'm joined by one of our Medicine the Essentials co-founders, Logan, who's just waving. So today we'll be going through an approach to interpreting ECGs, as well as a bit of interactive. It'll be very interactive, and I'll be asking you a lot of questions about ECG interpretation. And then I'll hand over to Logan, who will go through an approach to interpreting arterial blood gases. Okay, so just to emphasize before we start that all our talks are free, and we really hope that each of you can provide us with feedback at the end. So Logan will put into the chat a feedback link. It's just a link to a Google Forms document where you just asked a few simple questions. It just basically helps us improve upon future sessions. Just another heads up for all of you is that we will be recording the session for YouTube, especially to allow access for other participants who aren't able to make today's session, as we do have a cap of 100 participants currently. There will also be a dedicated Q&A session at the end. So if you have any questions, you can keep them until the end or just pop them into the chat, and Logan will try and answer them, and we'll go through them in more detail at the end of the talk. Okay, so I'm gonna start off with ECGs. The first part of the talk might be an hour or just over an hour, and then hopefully Logan will have a bit of time to go through ABGs. But I just want to start with a bit of physiology. I'm just gonna get the pointer out, or highlighter, get the laser pointer. Okay, so this is working quite well. This is from Wikipedia. So just in terms of the relationship between cardiac conduction and the ECG. So as I'm sure all of you know, the first wave on an ECG is the P wave. So this wave here. And this indicates atrial depolarization. And during this is when the atria are contracting. So basically atrial systole. And the P wave is the first wave on the ECG because the action potential in the heart is generated at the SA node. So this is the SA node up here. So the action potential is generated, moves down through the internodal pathways, and then down to the AV node. And this creates a positive deflection known as the P wave, the first positive deflection. And just to emphasize that this entire little tracing here is basically your standard lead 2. So most general ECG tracings, and also just the leads you'll find at the tracings you'll find at the bottom of most ECGs. So the will be a standard lead 2 tracing. And then, so SA node depolarizes here. The impulse arrives at the AV node around about here at the peak of the P wave. The impulse then passes the bundle of His and then goes down to the bundle branches and then to the Purkinje fibers. And then we move to the QRS complex, which I've just drawn this because I find it quite useful to try and understand how the QRS complex is actually formed from this. So once it goes down the bundle of His, the impulse goes down the left and right bundle branches, so left and right bundle branches, and there's septal depolarization from left to right. And this is really important because this is how you form your ECG vector. Because all of this is basically a vector showing the net, basically electricity or current that is flowing through the heart. So here in diagram 1, you see that the impulse goes from left to right. So you see from left to right and indicated by these green arrows. So the net vector is basically going towards the right. And this causes the small negative deflection, also known as the Q wave, on the ECG. And then in terms of the second diagram here, the impulse then moves down the bundle branches and then into the actual ventricles. and then the mean vector as it's moving down towards the apex of the heart, where the net electrical activity is, there's a positive deflection, and this creates the R wave. Okay, then we move on to the third diagram here, where the electricity then moves from the endocardial surface, so inside here, to the epicardial surface, and it causes a downward deflection because as you can see, the electricity or the net vector is moving away from the apex, so away from this direction. And then finally, the slight negative deflection at the end just shows where the final areas of the epicardial surface are being depolarized, and it causes a slight negative deflection. So that's basically how you get your QRS in a nutshell. And then from there, we move on to the T wave. So the T wave indicates ventricular repolarization, and this is when the ventricles relax after contracting. And we'll go through each of the segments in more detail in the next few slides. So basically, you can just have a look here. Impulse starts up here, generated down to the AV node, down the bundle of His, then to the left and right bundle branches, and up and out. And that's how the waveform's created. Okay, so today we're going to be going through a step-by-step approach. I have to be honest, I used to look at ECGs and spot diagnose, but I found that it's much better to go through an ECG systematically so that you don't miss anything important. And also just makes interpreting ECGs much easier if you go through the step-by-step approach. So firstly, the most important aspect is to confirm the patient's details. So look at their name, date of birth, the time of the ECG, and the paper speed. And we'll go through each of these in a few seconds. And then importantly, another thing to look at is the clinical details. So is this a patient in A&E, or is this a patient in the ward? What's a bit of their past medical history? And this is something you will get in an OSCE, or even on the ward. You'll have maybe a nurse will call you and say, this patient's been on the ward for a week and they're having chest pain, and they're known with previous MIs. So that the background clinical details are very important. And then how I like to do my next steps are looking at the rate, then rhythm, and then I analyze the waveforms, basically from moving from left to right, and then coming up with an actual diagnosis at the end. Okay, I'm not sure if you guys can annotate any of the slides, but does anyone want to just explain or name the different parts of an ECG that they know of, the different waveforms? So you can unmute yourselves or put it in the chat. Probably better just to unmute yourself. Okay, so yes, PQRST, PQRST. Any other segments that you've heard of or important sections of an ECG? PR interval is good. Yep, PR interval, PR segment, RR interval, good. ST segment, QRS complex. Yeah, it's QRS complex, not really QT segment. Yeah, good. Okay, that's great. Just gonna close these comments so we can carry on. Okay. So I've just annotated this ECG. So the actual patient's details have all been blanked out. So we start with, like we said, confirming the patient's details. So this is Mrs. Hart. Her date of birth is the 1st of January 1961, and the time of the ECG as well as the date. The timing is important because if you have a patient, for example, with chest pain, you want to know the time at which this ECG was taken in relation to the time of the onset of the chest pain. So that's why that's really important. And then also looking at the timing of ECGs, you can compare multiple different timed ECGs and look for any changes in the waveforms. So we'll start with the P waves, which I've just indicated in green. An easy way to find your P waves, if you're having trouble finding them in other limb leads, is to, because it's normally quite easy to see the P wave on standard lead 1. So you can plot the P wave here and actually just go down, and then you'll find your other P waves. So just an easy, a quick tip of how you can look for other P waves. They generally should be there. So for example, here you can't really see the P wave, but if you can see it here, or even here, you could go up and find actually that's where your P wave would be. And then we'll go to Q waves. So generally you shouldn't see Q waves besides in lead 2, lead 3. So you can see a tiny little negative deflection there. That's your Q wave. Sorry, something else I didn't mention is after you mention your patient's name, date of birth, time of ECG, it's very, very important to look at the paper speed, because this tells you whether or not this is a standard paper speed of 25 millimeters per second, or if it's 50 millimeters per second, then you need to change how you interpret a small or big square. Generally in exams and on the ward, all ECGs will be a standard paper speed. It's only if someone by accident changes the paper speed to 50 millimeters per second, which I have seen, which is really confusing. So at a rate of 25 millimeters per second, one small square becomes 1 millimeter and one large square is 5 millimeters, or one small square is 40 milliseconds and one large square is 200 milliseconds. So it basically just tells you the rate at which the ECG is able to output the trace at. At the bottom here, this is also really important, as this is called your rhythm strip. And generally your rhythm strip is always with standard lead 2, because like I said before, that shows you the normal basically vector or current of how the electricity flows from the SA node down the AV node and then down towards the apex. Okay, so we've seen P waves, Q. Now this upward deflection is your R wave. Okay, so you can see R waves here, R waves. And then here you can see it would be a downward deflection here. It's your R wave. And then the S wave is then, I'll show you an S wave here, here, here. Okay, and then finally your T wave, which is after your P QRS complex, you get your T wave. And again, you can just, if you're struggling to find or visualize the T waves, you can plot in a lead where you can see it well, and then just go down. That's a T wave, that's a T wave. And then you have these are your chest leads, so V1 to V6. And then you have your limb leads, which are leads 1, 2, 3, AVR, AVL, and AVF. J point, don't worry about that for now. We will go through it in a bit. And then you have your RR segment, and we'll go through ST segments later on. So don't really worry about it. I just wanted to bring in the simple waveforms in this slide. Okay, so once you've looked at, confirmed the details of the patient, their name, the time of the ECG, as well as the paper speed and a bit of the clinical details, you move on to calculating the rate. So like I said before, 5 big boxes are equivalent to 1 second. And generally at the bottom of an ECG, there are 10 sets of 5 big boxes. If you have a standard tracing and standard length. So like I said before, one small square on an ECG is 40 milliseconds or 0.04 seconds. One large square is 200 milliseconds or 0.2 seconds. And then again, this is 10 millimeters, which is equivalent to 1 millivolt. Okay, a few of the basics again. So in terms of heart rate, a normal resting heart rate is between 60 and 100 beats per minute. Tachycardia is generally a heart rate more than 100 beats per minute, and a bradycardia is less than 60 beats per minute. So the way in which we calculate the heart rate, if there's a regular heart rhythm, you are able to calculate the rate using counting the number of large squares present in one RR interval, and then dividing 300 by this number. So we do have some examples coming up. If, however, your rhythm is irregular, this method doesn't work. So what you could do instead is count the number of complexes on the rhythm strip, and a rhythm strip is generally 10 seconds long, and multiply this by 6. Okay, so in terms of rhythm, you can, I think we're missing a slide actually. Let me just check. Okay, no, it's coming up. In terms of rhythm, you can have regular rhythm or an irregular rhythm. So in terms of a regular rhythm, generally the RR intervals are constant. And in an irregular rhythm, when you try and plot RR intervals, you'll find that the distance between RR intervals is not constant and is actually varying. If there's a pattern with the difference between the RR intervals, then you could find a regularly irregular rhythm. This is if a pattern can be found. And if there's just a haphazard organization and you can't actually find a pattern, then it's irregularly irregular and there's complete disorganization. And this can be in the case of atrial fibrillation or ventricular fibrillation. Okay, so how do we actually work out which rhythm it is? So if you take your rhythm strip at the bottom, which if we say this is a rhythm strip but going on for longer, you can take a piece of paper, so blank paper, and mark out each of the RR, well, each of the peaks of the R waves. So you put a little mark on your piece of paper here, put a mark here, and then you can take that piece of paper and move it along and see, using this interval, to gauge as to whether the next segment is the exact same size. So in a regular rhythm, this should be constant and shouldn't change. The RR interval should be the same. And then if it's regularly irregular, if you plot a few of these, you might notice a repeating pattern. And then, of course, irregularly irregular, there won't be any pattern. So each of these intervals are going to be changing. So the next R wave could be somewhere here, then the one after that somewhere here, and so on. So this is just depicting sinus rhythm. So as I said before, there's a regular RR interval. If you took a piece of paper and marked these out as you went along, you would get the same repeating pattern. This is atrial flutter. So although there's a regular RR interval, there's a different morphology of the P waves and also just the QRS complexes. But we won't really be going into too much of complicated details surrounding atrial flutter and ventricular bigeminy, etc. today, but we might host a second session for that. And then here you have ventricular bigeminy. So here you actually have a pattern where it's regularly irregular. So you can see there's a P wave, QRS complex, T wave, and then another complex, and this is repeated, this pattern. And then next we have bradycardia, so prolonged PR intervals. Sorry, have I been muted the whole time? No. Okay. No, it's just said the host has muted you, but I am the host. sorry, just need to close this. But we'll go through heart blocks in a little bit. And then finally, the one where there's complete disorganization and you can't actually plot the RR intervals would be your irregularly, this is wrong. Irregular RR interval in atrial fibrillation. So this is actually a typo, and I actually took this from a textbook, so it's a bit worrying. Okay. Okay, so can anyone try and calculate the rate here? You can just put your answer into the chat. So tell me what method you'll be using and your answer. My pointer is just not working now. Logan, maybe if you could read out the answers, because I can't actually access the chat.
Sure. So we've got 136, we've got 100,
okay,
75, and from E, they're saying 300 divided by 4.
Okay, so good. Thanks, Logan. So we'll go through this now. So there's no, so 300, okay, so we'll look at the number of big squares. I like to use the, if there's a rhythm strip, I like to use the multiply by 6 method. So count the number of complexes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and then 13 multiplied by 6. Or you could use the method of counting the number of RR intervals. I mean, the number of big squares between the RR intervals, which is also slightly less accurate. So there's 1 big square here, 2, and then 3 if you count that first part. So about 4. So I'd say, yeah, you could divide 300 by 4. So that's correct, around about 75, or the other way that I was doing it would give you around about 78. So you can see no one's looking for a precise heart rate, just a ballpark figure to tell you whether it's within the normal range, or if there's tachy or bradycardia. Okay, can anyone calculate the rate here? And Logan, if you can just read, read out what.
So Yarissa, there was a question, would you ever use big squares to the nearest 0.5 between the RR intervals? And I've just said, yeah, you can do, yeah.
Yeah.
Fine. And you
so
have
you can absolutely do that. Will give you a more accurate answer, actually.
Yeah, and we've got answers from lots of people: 50, 48, 48, 50, 48, 50,
yeah.
50.
Yes. So well done. If you use the standard lead 2 at the bottom, you'll get an answer of 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 6 is 48. And then this will underestimate slightly because, see, you've missed this one complex, which you can't actually add in. But as I said before, it doesn't really matter. You're just looking at around about what the heart rate is. And if you use the number of big squares between the RR intervals, which is also pretty simple on this one, of 1, 2, 3, 4, 5, 6. So 300 divided by 6 is 50 beats per minute. So like I said, there's a little bit of underestimation with this method here.
Yarissa, sorry to interrupt. Yeah. There's a question: what happens if this ECG shows 50 millimeters per second? What rate would this be?
Well, if it's 50 millimeters per second, then every so on a normal one it's 25.
Fine,
So each
yeah.
big square would be 10 millimeters. So each big square would be 0.4 seconds. And you just have to go with that. So it'll just be double. Each big square will be double. Each small square will be, instead of 0.04 seconds, would be 0.08. And then you'd calculate based on that. But remember, if you're doing a 50 millimeters per second, you should go back and repeat the ECG, because you are going to see pathology where you're not used to interpreting the ECG that way. Everything looks much bigger and just distorted. Yeah. So waveform analysis, just a quick recap. So we have the P wave, which is depolarization of the atria in response to the SA node being triggered. And then the PR interval, which is delay of the AV node to allow ventricular filling. QRS complex, which is where depolarization of the ventricles happens, which triggers the ventricles to contract. And then the ST segment, which is the beginning of ventricular repolarization, and it should always be flat. And then finally, ventricular repolarization, where there's filling. Okay, so moving on to P waves now. So the P wave looks like this, because in the heart, actually what's happening is that the right atrium is depolarizing before the left atrium, which then gives this net vector of the P wave, or the net appearance or morphology of the P wave. So generally, when you see this buffered P wave, it's generally because this is signifying the right atrium and this is the left atrium. So the P wave is the first deflection of the isoelectric line in a normal sinus rhythm. An isoelectric line is basically a straight line, okay? So it's not positive, not negative, it's just straight. And like I've said multiple times before, the P wave represents atrial depolarization. In terms of analyzing the P wave, you need to firstly look at the location of the P wave. And what I mean by this is there a P wave before every QRS complex? And is every QRS complex followed by a T wave and then a P wave? Okay. And then in terms of the P wave deflection, is the P wave positive or negative where it should be? Where it should be positive, and is it negative where it should be negative? And then finally, the morphology is just looking at the height and width of the P wave. Is it a very peaked P wave in some chronic lung conditions where you can get P pulmonale, or is it a buffered P wave with P mitrale? Don't worry about those, I'm just mentioning them. Okay, so in terms of a normal P wave, the P wave should always precede every single QRS complex in normal sinus rhythm. It should be upright in leads 1, 2, AVF, and V2 to V6. It is always inverted in AVR. And this again is just because of the flow of current and where the direction in which AVR is looking in relation to the apex of the heart. And that's why the P wave looks negative in AVR. It's usually biphasic, so it looks a bit like this, biphasic in V1, and it can be variable in lead 3 and AVL. It's generally a nice round shape and looks uniform in all leads. And in terms of the length of the P wave, it's generally 2.5 small squares, and as well as less than 2.5 millimeters in height. Yeah. So yeah, it should be less than 3 small blocks wide, or less than 120 milliseconds. Okay. Just an important note, why I mentioned that a P wave can occur after a QRS complex is because sometimes you can get P waves being basically in some rhythm, maybe I shouldn't mention this, it's going to confuse you guys. It's fine, I won't mention it now, maybe in the second session, but just remember that in sinus rhythm, you need to have a P wave before every QRS complex. In terms of the P wave amplitudes, so you can have a reduced P wave amplitude, so a small P wave, for example, in hyperkalemia, so a high potassium, and like I said before, a really tall peaked P wave in something called P pulmonale, where there's right atrial enlargement because of chronic lung disease, which is caused cor pulmonale. Okay, not changing slides. Okay, so moving on to the PR interval. So the PR interval is the time from the start of atrial depolarization, conduction through the atrium, AV node, and bundle of His until the start of ventricular depolarization here. So from the start of the P wave until just before the start of the QRS. You should generally always measure the PR interval in lead 2 and count the squares from the beginning of the P wave to the start of the QRS. So don't try and count from the top, from the middle of the P wave. No, start counting from the beginning of the P wave to the end, just before the start of the QRS complex. A normal PR interval is generally 120 to 200 milliseconds or 3 to 5 small squares in length. It should be a fixed length over the entire rhythm strip. If it's not, we'll go through reasons as to why this could be the case. And it should always be on an isoelectric line, so always on a flat line. Okay, so there are cases where you will have an abnormal PR interval. So you can either have a short PR interval or a long PR interval. Short PR intervals are when the interval is less than 3 small squares or less than 120 milliseconds. And this can be caused by ectopic beats or accessory pathways, such as Wolff, Parkinson, White. A long PR interval occurs when there's slower conduction through the AV node and can result in heart block, different types of heart block, depending on the length and pattern of lengthening. And so long PR intervals are more than 200 milliseconds. Okay, so we're going to go through heart blocks now. So there are 4 different types of heart blocks. We'll start with first degree heart block. So generally, first degree heart block is benign. It's generally an isolated ECG finding, especially or only if the patient is hemodynamically stable. There's no treatment needed. And with first degree heart block, so we're just going to go through, is there a P wave before every QRS? So the answer is yes, there is. And then we would have calculated rate and rhythm already. So the rhythm looks, the RR, distance between the RR intervals looks regular. And then we'll go on to the PR interval. So the PR interval here, you can see from here until here, it's more than 200 milliseconds. So it's prolonged. But if you have a look, each of the PR intervals is constantly prolonged. And this is a hallmark of first degree heart block. The PR interval is it's constantly prolonged and there are no dropped P waves. So there's a P wave before every QRS complex and the PR interval is prolonged. And basically the cause of first degree heart block is a delay in the conduction from the atria to the ventricles. Causes can be increased vagal tone, hyperkalemia, as well as it can be normal in healthy athletes. Now we move on to second degree heart block, type 1, also called Wencker-Bach or Mobitz 1. So here there's progressive PR prolongation So you can see the PR interval here is 1, 2, 3, 4, 5, 6 small squares, and here it's 3, 6, 7 small squares, and you can see it's getting progressively longer until there's a dropped QRS complex. So there's a P wave here, but no QRS complex following the P wave. So if we have a look, we have a P wave here, QRS complex. We have our T, then another P wave here, QRS complex, T wave, P wave, QRS complex, T wave, P wave, no QRS complex. So there's the hallmark of second degree heart block is progressive PR prolongation until there is a dropped or non-conducted P wave. And then the PR interval, generally straight after that dropped beat. So this PR interval, you'll find that it's the shortest PR interval. So it will go back to about this length. And causes for this can be drugs like calcium channel blockers, digoxin, beta blockers, or amiodarone. It can also be found in inferior MI. Again, this is generally benign, especially if the patient is hemodynamically stable and you wouldn't actually need to proceed to pacing or anything like that. So basically, as in first degree heart block, there's a functional suppression of the AV conduction. So either by drugs or something pathological like an MI. But again, if they're hemodynamically stable, there's no treatment needed. Another important thing is that with secondary degree heart block, you can get repeating patterns. So you can get a 3-2 block where you have for every 3 impulses conducted, there's 1 dropped, and you'll see that repeating pattern occurring. Now with second degree heart block, type 2 MOBITs, there is failure of conduction at the level of the bundle of His or Purkinje fibers below the AV node. And this is generally due to an actual structural cause, so structural damage of the conducting system. So this is actually very serious, and there's a risk of asystole. So asystole means flatlining and not having a cardiac output. So this needs urgent intervention, cardiology referral, and pacing. So causes for this would be anterior MI, inflammatory disorders like rheumatic fever or myocarditis. And the hallmark of this is that they are dropped, there's a P wave and then a dropped QRS complex with fixed PR intervals. So the PR intervals are constant, but at varying intervals, there are dropped QRS complexes. It's quite random. There's no pattern with MOBITs type 2. That's how it differs from type 1. So type 1, they're progressively prolonged until there's a dropped one. Here, the PR interval is fixed, and then there's occasional dropped QRS complexes. So this is dangerous. And then even more dangerous, or actually just as dangerous, is third degree heart block, called, or also known as complete heart block, where there's complete AV dissociation, which means there's complete dissociation between the atria and the ventricles. So they're really not talking to each other. The impulses generated by the atria are not moving down and getting captured by the ventricles. So here, the P waves are just erratic. You can't predict when a P wave will happen, and they're not always, and the QRS complexes are also independent of the T waves, of the P waves, P waves. So they're intermittent, non-conducted P waves, intermittent, intermittent non-conducted P waves are here. Here you just have complete dissociation where you have random P waves, random QRS complexes, and there's no relationship between the two. Okay, so I found this nice mnemonic, which might be helpful for you guys. So if the R is far from the P, then you have first degree, longer drop, then you have Wenke back. If some P's don't get through, then you have MOBITs 2. If P's and Q's don't agree, then you have a third degree. Okay, so Can any of you tell me what these 3 rhythm strips show? Okay, so someone has said sinus tachycardia for which one? Yep, the second is sinus tachycardia. Anyone have an answer for the first and the last? Is it just bradycardia the first, or? Yeah, sinus bradycardia. And the third bradycardia, no. Try again. Anyone know what the third one is? It's a bit tricky. Okay, I'll explain. No, it's not heart block. Okay, let me just explain and close this. When I use the laser, it's very difficult to close the chat.
I think Martina has it, unless I'm wrong. First degree heart block.
No, sorry.
No. Oh, sorry.
That's why I was saying no. Yeah, so Zar Floyd Smith or Floyd Smith has it. It's sinus arrhythmia. Sorry, I'm just trying to get this silly pointer. When it's a highlighter, it's really hard to close the chat. Okay, so the first one, now I have to go back to this laser pointer. The first one is sinus bradycardia. Well done to all of you. So like I said before, can be normal in athletes. And if we count the number of big squares between the RR interval, 1, 2, 3, 4, 5, 6, 7, 8, just about 8. So just because it's just under 8, it'll give you a rate of about 40. And there is a P wave before every QRS complex, and there's the regular RR intervals. So this is sinus bradycardia. Again, bradycardia is when the pulse rate is less than 60 beats per minute, between 40 and 60 actually. And then the second one, like you guys have correctly said, is sinus tachycardia. So again, RR intervals are constant. There's a P wave before every QRS complex. So P wave, QRS, P wave, QRS, P wave, QRS. And the distance between the RR are about 2.5. So someone asked this before, can you do 2.5? So you just go 300 divided by 2.5, and that would give you the rate. And that's the perfect rate. And then finally, this one's a bit tricky. Sinus arrhythmia. It's not a heart block. Okay, let's go through why it's not a heart block. Firstly, is there a P wave before every QRS complex? P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. So yes. So we know it's sinus, number one, because if a P wave is before every QRS complex, it's a sinus rhythm. Is the RR interval constant? From just eyeballing it, it's constant. And what is the RR? Eyeballing it, it's not constant. So let's see, this RR interval is 1, 2, 3, 4, 5. 5 big squares and 1, 2, 3 small squares. And this one is 1, 2, 3, 4, 5 big squares. And so this is 3 small squares, and this one is about 4 small squares. And then this one is 1, 2, 3, 4, 5. And 1, 2, 3, about 3.5 small squares. So they're almost identical RR intervals, but not just. And then this one is really long. 1, 2, 3, 4, 5, almost 6 big squares. So you know this is a really long RR interval. Okay. Other important features. Okay, let me just go through. Yeah, so the RR intervals are, this one is mainly prolonged, okay? But the P waves are present before every QRS, and the P waves have the same morphology, same shape in all of them. So, and then the PR interval is about 1, 2, 3, 4, 5, 6 small squares, and we check if it's the same here. 1, 2, 3, 4, 5, 6. It's actually about 5.5. 1, 2, 3, 4, 5.5. 1, 2, 3, 4, 5.5. Yeah. So the PR intervals are also constant. So this tells us that this is all pointing towards a sinus rhythm and not a heart block, because the PR intervals are not prolonged. They're 5 small squares, 5.5 small squares. It's hard to see here, but it's about 5.5. And the only thing that tells you it's sinus arrhythmia is because the RR intervals, they're not exactly the same, the distance. Here it's prolonged because in sinus arrhythmia, as we breathe in, you get prolongation of the time period between the RR intervals. And so this was what tells you this is sinus arrhythmia. So if you get this in an OSCE, it's sinus arrhythmia because they're P waves before every QRS. The P waves have the same shape. The PR intervals are constant and not prolonged. So they're about 5 small squares. And then the only thing is that the rhythm is not regular because here the RR interval is prolonged. But there's no dropping of QRS complexes anywhere. And there's no prolongation of the QRS complexes. So this is why it's not heart block. Okay, can anyone tell me the PR interval here? So can you just want to read out what?
We've got no takers just yet, so it's really difficult to kind of to see this, Eurus, unfortunately.
Really? The PR interval?
Yeah.
I'm not sure why, but on my screen it looks quite clear.
Okay. My screen.
Okay, let's go through together then.
Some people are saying 5 small squares. Some people are saying they can't read, unfortunately, but
Okay.
primarily 5 small squares or 4 small squares.
Yeah, so it's between 4.5 to 5, because I'll give you that it's quite difficult to see on a screen. But 4.5 to 5 small squares. So if you go to standard lead 2, beginning of the P wave here, and then we start counting 1, 2. P wave starts basically. Yeah. 1, 2, 3, 4, 5. About 5. 4.5 is probably the most accurate because, yeah, like you said, it is quite tricky to see. And by the way, I think I got this from Life in the Fast Lane. So if any of you want to go have a look, they have a good series with 100 ECGs. You can test yourself and then get the answers for each of them. So it's quite good. And we're not affiliated with them in any way. Okay, so moving on to the QRS complex now. So this is part 1 of the QRS complex. Important elements of the QRS complex is firstly the width. This tells you the length of time of ventricular depolarization. It's normally between 1.5 to 2.5 small squares. And there's a broad QRS complex if it's more than 3 small squares, and a narrow QRS complex if it's less than 1.5 small squares. In terms of access, the only method I use is one that I learned in medical school and still use till today. So basically, I'll just mention all the points here and then we'll go through it practically. But I like to look in the limb leads and find the most equiphasic or isoelectric lead. So basically the lead in the limb leads, in which the positive R wave and the negative S wave basically cancel each other out. So if you look here, Here the R wave is mostly positive, the S wave is slightly negative. So this would not be the most equiphasic lead, but this is the most equiphasic lead because of this, the size of the R wave here is almost identical to the size of the S wave. So it means they basically cancel each other out. And then in this last diagram, the R wave is very small and the S wave is very large. So it's mostly a negative deflection. So overall deflection. And then after you find the most equiphasic lead, so for example, it would be this one, you look at the lead perpendicular to this on the QRS axis. And I have an easy way of remembering the perpendicular lead, which I'll show you in a little bit. But if you just have a look, you basically want to, if for example, we say this is lead 2, you want to look at the lead perpendicular to this, which is AVL. So 90 degrees to lead 2 is AVL. And this is the lead you'd be looking at to see whether or not the QRS complex is positive or negative. And then in the lead, 90 degrees to the most equiphasic lead, which is AVL, you then need to look at AVL itself and see, is the complex mostly positive or negative in AVL? If it's mostly positive, it means that the current is running towards AVL. If it's mostly negative, means the current is running away and you'd have a right axis deviation versus a normal axis. So it might sound really confusing right now, but we'll go through some examples and should clarify all of it. Okay, so this is example number 1. So step 1, we find the most equiphasic lead. So for me, I would say that the most equiphasic lead for me is AVL. So let's go through it. Lead 1, R wave is mostly positive and the S wave is very small. So this can't be the most equiphasic. Same with, so this is lead 1. AVR only negative, so no. This one mostly only positive, only positive, only positive. And here is positive R and an equally negative S. Okay, just remember that you can only use this equiphasic method you can use it for every single ECG you have, but you only look at the limb leads. You ignore the chest leads, which would be on the side. And this is why I've cut just this portion. So if we're saying this is the most equiphasic lead, we need to look 90 degrees to this, which remember I said was lead 2. But I have an easy way of remembering this. If you imagine, I'm going to try annotate the slide quickly. Let's see who will let me. Okay, I think it will let me. Oh, good. But that's wrong. I got so happy that now I've made a mistake. Okay, it's gone. Okay, so if you look at this, it's basically a star to a way to remember which is 90 degrees to what. So at the beginning I said AVL is 90 degrees to lead 2. Okay, so we said AVL is the most equiphasic in this ECG. So 90 degrees to AVL is lead 2. And then a way to remember this is to just think of it as the star over your ECG. So say, for example, if this was the most equiphasic lead, then 90 degrees to it would be AVF. If this was the most equiphasic lead, 90 degrees to AVR would be lead 3. Just a quick way of remembering instead of trying to think of the axis itself. But it's the same principle. If you look at lead 1, what's 90 degrees to lead 1? AVF. It's just a quick way of remembering what's perpendicular to it. So our answer is that lead 2 is perpendicular. Now we go to lead 2. Is lead 2 is the QRS predominantly negative or positive? It is positive. So our current is going in the direction of lead 2 because in lead 2, the QRS complex is positive. So our axis is plus 60 degrees. And is that the answer? Yes. So that's the answer, okay? We'll go through a second example. Okay, so now, again, we're looking for the most equiphasic lead in the limb leads. Okay, so it's not lead 1 because the S wave is much more negative than the R. It could be lead 2. It's not lead 3. It's not AVL. It's not AVR. It's not AVF. So it's lead 2. So what is 90 degrees to lead 2? Draw a little star. AVL is 90 degrees. Is AVL mostly negative or mostly positive? It's mostly negative. So we go to AVL. Is it going towards AVL? No, because it's negative. It's going away from AVL. So this is right axis deviation, and the axis is about 150 degrees. So you can get a right axis deviation in the case of right ventricular hypertrophy. Okay, if you can just put in the chat if all of you are following what I've been saying, or if we need to go through it one more time. We could probably go through it at the end, just if some have understood and some haven't. Okay, so someone has asked if lead 2 was negative. What do you mean if lead 2 is negative? If lead 2 was negative, then you'd look for, oh, sorry, that was the previous one. Okay, sorry. Yeah, so you can save those type of questions, take a screenshot and then keep them for the end, then we can go through. Okay, so I'm glad all of you understand this so far. And then just in terms of axis, something I didn't go through before. So normal axis is between here and around about here. And then this is right axis in the blue. And this is left axis deviation, right axis deviation, extreme right axis deviation. And the brown is a normal axis. So minus 30 degrees to plus 90 degrees is a normal axis. Okay, QRS complex part 2. So when you're looking at, we're moving to the chest leads now. So these are the chest leads. Generally in the chest leads, can all of you see this pointer though, when it's the pen? Yep. Oh, so someone has just asked, how do you know without the diagram in this slide? So you do have to memorize that AVL is minus 30. You basically have to have a picture of this in your mind to remember where AVL is, where AVF is, and the degrees, basically. That's not something you'll have with you. Okay, so in terms of the QRS complex, if you look at V1 and V2 in a normal sinus ECG, you will see that V1 and V2 have a small r, big S pattern. So basically that means the R is really small and the S is really deep. R is small, S is deep, okay? And if there's a Q wave in V1, 2, or V3, this would be pathological, okay? As the V wave, as V1 continues, you will notice that the R wave becomes bigger. So gradually, the R wave gets bigger until the R wave becomes more predominant than the S wave. So then you get big R, small s, because now the R is the dominant one and the S is just small. Okay, so this is referred to as normal R wave progression, where the R wave starts off small in V1 and gets progressively bigger and bigger until it's larger than the S wave. Okay, and here you can see poor R wave progression, because in V1 you can see the R wave is there. It's there in V2, V3, but it's not getting any bigger. it's almost the same size as the S wave. It's not getting any bigger than the S wave. And causes for poor R wave progression could be an anteroseptal MI, left ventricular hypertrophy, Wolff-Parkinson-White, left bundle branch block, and don't ever forget dextrocardia. If your ECG is looking a little bit funny and your P wave in lead 2 is not upright, always think about dextrocardia. And then finally, just in terms of Q waves, a normal Q wave can indicate septal depolarization and is normally only seen in V5, V6, lead 1, and AVL. So you can get a little Q wave in those leads. Pathological Q waves, however, are more than 1 millimeter in width or more than 2 millimeters deep, or if they're more than 25% of the total QRS amplitude, especially in leads V1 to V3. Okay, so just QRS progression again. So the R wave should become bigger and bigger and bigger until it overpowers the S wave. So this is poor R wave progression down to the bottom. Or actually, this is late R wave progression. So it's staying the same size and then only very late becoming larger than the S wave. This is normal R wave progression, and this is early R wave progression where the R wave is becoming really big really early on. You don't need to know the details of this. You just need to know that there are some causes of poor R wave progression, which can be here in the bottom. And remember, it can also just be a normal variant. Okay, so now we're going to go into an approach to tachycardia. In terms of tachycardia, how I like to look at it is after I've looked at the rate and rate, I then look at the rhythm. And I would already know whether it's regular or irregular. So I would know this part already. And then I would measure the QRS complex size. So if it's more than 3 small squares, it would be a wide QRS complex, and then narrow if it's less than 2.5 to 3. So just causes for tachycardia and a wide QRS complex would be with a regular rhythm, could be ventricular tachycardia, sinus tachycardia with aberrant conduction. So this is basically just means a sinus tachycardia, which we saw, but aberrant conduction means not all the beats are moving down from the atria to the ventricles. And then supraventricular tachycardia with bundle branch block, or supraventricular tachycardia with Wolff-Parkinson-White. And then a wide QRS complex with an irregular rhythm could be atrial fibrillation with bundle branch block, atrial fibrillation with pre-excitation, or ventricular fibrillation. And then in terms of a narrow QRS with a regular rhythm could be sinus tachycardia, supraventricular tachycardia. Here, there would be no P waves evident. Could be atrial flutter, where you get sawtooth shaped P waves, which we won't really be going through in this talk. And then a narrow QRS complex with an irregular rhythm would be atrial fibrillation, multifocal atrial tachycardia. In this, you basically have different foci in the atrium, which are triggering at the same time, and they're basically overpowering the SA node, which is the usual pacemaker of the heart. So you get differing P wave morphology. So in all the different leads, you're going to see different heights and widths of P waves, and that could indicate that it's MAT or multifocal atrial tachycardia. Then finally, atrial flutter with variable conduction. Okay, so can anyone try and calculate the axis here? Any answers, Logan?
We have LAD, but we don't have an actual value yet.
Okay. If they tell me the value, that might be a bit helpful.
We've got 30.
Good. Okay, so the axis is 30 degrees, yes, and it's not LAD because remember I said on 30 degrees. Wait, do they mean negative 30 or positive 30?
We have 30, so I assume positive.
Okay, let's go through it. So,
Positive.
which is the most equiphasic lead? I think in most of them I've made lead 2 the most equiphasic. So it's
Lead 2.
Does everyone agree? If anyone agrees, speak now. Okay, so most equiphasic lead 2. Perpendicular with our star is AVL. We look at AVL. Is AVL mostly positive or mostly negative? AVL is mostly positive. So we're going towards AVL. So it is negative 30 is the axis. Not positive if you were thinking positive. Let's see what's in the chat. Yeah, negative 30, good. I think that person meant negative 30. Very good. Oh, you guys are catching this. It makes me so happy. For those who don't understand or still confused, I'll spend some time at the end if you need it. Can anyone tell me the axis of this one? A bit more tricky. Oh my gosh, well done. You guys are so good. So it's right axis deviation and spot on 120 degrees and positive. So we'll go through it now. Which is the most equiphasic lead? I would say lead AVR. Does everyone agree? Because lead 1, the S wave is slightly bigger than the R wave, whereas AVR, they're almost the same size. So what is 90 degrees to AVR? Lead 3. Is lead 3 mostly positive? Yes. So it's going towards lead 3, which is 120 degrees. So well done. Okay, so now I'm moving on to bundle branch blocks. I realize that this talk is taking quite long. It's just that I had to put a lot of content in here to get through the basics. So we might run over time if that's fine. Again, if some of you want to leave at 7:30, that's absolutely fine. You can catch it on YouTube. It will be either tonight or sometime in the week. I'm just really busy. Okay, so bundle branch blocks. We have left and right bundle branch blocks. So if you look at, or if you remember how the conduction worked, remember we said that the electricity goes from left to right, and that's why you get this, you get that little negative deflection in lead 2. Okay, but if you have a bundle branch block, so either a left bundle branch block or a right bundle branch block. I'm not sure if you guys can see me pointing at things. Logan, can you?
Yes.
Yeah, okay, good. So in left bundle branch block, there's a problem with the left bundle. So the impulse from the AV node can't be conducted down. So depolarization happens in the right bundle, then only later in the left bundle. And it has to basically occur via other pathways because this left bundle is not working. So what you'd see on your ECG is that the QRS duration is more than 120 milliseconds. There is a dominant S wave in V1. So you see this here, dominant S wave in V1, and you have a broad monophasic R wave in the lateral leads. So in lead 1, you have this broad monophasic, just means that it's going in one direction. It's not like wavy or anything. It's just an upright R wave. So in lead 1, AVL, you have the same. V5 and V6, you see this broad monophasic R wave. And then There are no Q waves in the lateral leads. So lateral leads would be, for example, lead 1 and AVL. So you don't see a Q wave. So this is where the Q wave would be. And you don't see a Q wave here either. And there's a prolonged R wave peak time. So you can see the R waves are broad. So they're taking some time to peak, especially in leads 5 and 6. Then in terms of a right bundle branch block, your QRS duration again is prolonged, so it's more than 120 milliseconds. There's an RSR pattern, so that basically means, I'll show you in the next slide actually, what an RS, okay, so I can show it to you here. So if you see, the first positive deflection is the R wave, and then the negative deflection is the S wave, but then you're getting another R wave. So this is actually how we annotate it, is that this is big R because it's your normal R, big S, and then this is your extra R. So it's a RSR pattern. Some people say this is an M, and they fancy mnemonics of William and Morrow and all that stuff. But I prefer looking and understanding this instead of just jumping to the M pattern, because sometimes it'll be wrong if you're just looking for an M. And then there's a wide slurred S wave in the lateral leads, which I don't actually have depicted here, but you would see that. So in V5 and V6, we could see it, not really, maybe in my next slide. I think I jumped this. Okay, yeah, that's fine. Oh, I don't think I actually have I think it's later on in the examples, but it's fine. So now we're moving on to the ST segment. So the ST segment should generally be isoelectric. It's the time from the end of ventricular depolarization to the start of ventricular repolarization. So the end of the contraction to the start of when there's going to be relaxation, basically. Like I mentioned earlier on the third slide or so about the J point. So the J point is the junction between the end of the QRS complex and the start of the ST segment. So this is the J point here. So where the QRS complex ends and where the start of the ST segment is. And this is really important when you're trying to figure out whether there's an ST segment myocardial infarction, the J point, because that will determine whether or not there's ST segment elevation. And then, yeah, so the ST segment is from the J point until the first part of the T wave, which the first part of the T wave would be here. Okay, so in terms of ST segment abnormalities, you can either get elevation or depression. So you can see here, elevation depicted nicely. So your J point here, so we'd say our end of our QRS and start of our ST segment. So probably somewhere here. So ST elevation is when there's new ST elevation at the J point in two contiguous leads. So remember that to call it an MI, you need to be thinking about the amount of elevation there is and the number of leads it's present in. And this ST elevation needs to be in two contiguous leads of more than 0.1 millivolts. And for leads, but this is in all leads except V2 and V3. In leads V2 and V3, they need to be greater than or equal to 0.2 millivolts in men, or sorry, this is a mistake at the bottom here. I think this is meant to be woman. Yeah. And then here we have ST depression. So if we say the J point is somewhere around here, we can see that there's ST depression because the J point is displaced below the baseline of where it should be. So this is normal, abnormal. You can see where the baseline should be. And then again here, you can see this ST segment elevation where the J point should be, which would be around about here. Okay, so can anyone identify ST segment changes here? ST elevation in chest leads, okay, ST elevation in V1 to V6, okay. So yeah, correct, there's ST elevation in V1, 2, 3, 4, 5, and 6. But interestingly, there's also reciprocal ST depression in lead 3, you can see here. So if we say the J points around here, there's depression there, as well as AVF. So reciprocal changes are just changes basically opposite to where the territory of the infarct is. And they generally have, so say there's ST elevation here in the area opposite to the infarcted territory, there'd be depression. So in the inferior leads, we're seeing depression here. And this is, and then we also can see some Q waves in V1 and V2. Really? Well, it's tiny in here. And then also just here for anyone wondering, this is a PVC. So an early ventricular contraction. And then there's, it's happened so that it's actually going on to the next R and T wave. So there's R on T phenomenon happening here. Okay, so the T wave. So the T wave signifies ventricular repolarization. It's the first positive deflection after the QRS complex. It needs to be upright in most leads except for AVR and V1. And the T wave in V1 can be positive, negative, or biphasic. So it doesn't mean it's pathological. And you can have an isolated negative T wave in lead 3, AVL, or AVF. So looking at T wave morphology, you can get peaked T waves. So they're tall, narrow, and peaked. So this is your T wave. So P wave, Q, R, S, but the S is not really going any further, and your T wave. And where T waves are generally peaked can be normal in, sorry, a peaked T wave is never normal. I'm tired now. Hypokalemia. And then inverted T waves. So inverted T waves can be normal in children, and they are pathological if a patient has chest pain, and it could indicate myocardial ischemia, as well as it can be present in bundle branch blocks, or interestingly with subarachnoid hemorrhage or raised intracranial pressure. So your inverted T wave. And then hyperacute T waves. So it can be a feature of an early ST elevation MI. Biphasic T waves. So you can see that the T wave is kind of wavy. So you can have a T wave which is biphasic and first goes up then down, and this can indicate a MI, or if the T wave is the opposite, so if it goes down and then up, so something like that, it can indicate low potassium, so hypokalemia. And then finally flattened T waves. So it's quite a non-specific sign, doesn't always mean that there's pathology, but it can indicate hypokalemia or ischemia. Can anyone notice anything about these T waves? Just put in the chat. Inverted, good, in lead 2 and 3. Anywhere else? Very good. Inverted in lead AVF 3 and 2, good. Okay, so also inverted, so let me just close this. Inverted in lead 2, in lead 3. Let's have a look. Also inverted in AVF, inverted in so the upright here, upright, inverted in 4, 5, and 6 also. Okay, and then the T wave is in AVR. Can you see it's kind of biphasic? It's not completely grounded. Oh, sorry, pointing at the wrong thing here. So there's your P wave here, QRS, T wave. And then in V2, I'd say this is quite a prominent T wave. But again, isolated without any history, you'd need to know more about what's happening. I think this was actually a patient who had a myocardial infarction. So just to compare, for those of you who might be a bit confused, a normal ECG, like we said before, the T wave, so we're looking at, it should generally be positive. Hope you guys can remember that. And it should be upright in all the leads except for AVR, like in this normal ECG. And then V1 here is, you almost can't really see it, but you can see a slight negative deflection here. So it can be negative in AVR or V1, but in all the other leads, it should be positive as it is. So that's why there's a lot of T wave abnormalities in this ECG. Okay, QT interval, and we're almost at the end. So the QRS complex, like I've said multiple times before, represents depolarization. The T wave is the repolarization. So physiologically, the QT interval length changes with the heart rate. So in tachycardia, you have a shorter QT length. In bradycardia, you have a longer QT length. And this is why we need to correct QT intervals, because we need to correct according to the heart rate. Otherwise, we'll get a false positive or negative length of the QT, indicating QT prolongation. So normal QT interval in males should be less than 440 milliseconds, and in females, less than 460 milliseconds. In terms of calculating the corrected QT interval, which is QTC, there are various formula like Frederica, but the most commonly used one is called Bizet's correction. And it looks at the QT interval and the RR interval. So it's basically the QT interval divided by the square root of the RR interval. And there are lots of calculators online which can do this automatically. You just plug in your QT duration and then your RR, and then it gives you your answer automatically. In terms of QT interval pathology, you can get short QT intervals or long QT intervals. Short QT intervals can be caused by electrolyte abnormalities like hypocalcemia or hypothermia, digoxin toxicity, or short QT syndrome, which is very rare, or long QT intervals. Most commonly are caused by long QT syndrome. That's what LQTS stands for. It's an inherited condition. I think there are about 3 different types: long QT syndrome 1, 2, and 3. It affects 2 different channels, so the potassium channel or the sodium channel in the myocytes. Long QT intervals can also be caused by drugs, especially antipsychotic drugs. And there are actually about over 170 different drugs which can cause long QT intervals or prolongation of the QT interval. A lot of the new TB drugs also cause this. Long QT interval can also be caused by hypokalemia, hypomagnesemia, hypocalcemia, or hypothermia. So it's all the lows. So sorry, actually, no, there's a mistake here. This should be hyperthermia, I'm pretty sure. But I'll correct that for YouTube. And then myocardial ischemia, and then others can be post-cardiac arrest or raised intracranial pressure. So why is a long QT interval dangerous? It's because it increases the risk of ventricular arrhythmia, specifically torsades de poids or de pointes, however you want to say it. And this can result in sudden death. And this is basically what an ECG of torsades looks like. It looks a bit like a banner, or yeah. Okay, so a quick recap of what we've gone through. We have our P wave, Q, R, S, the J point, our T wave, R, okay, I've gone through the R wave, and then PR duration, PR segment, QRS duration, ST segment. Then don't forget, big square is 200 milliseconds, small square is 40 milliseconds, at a paper speed of 25 millimeters per second. Okay, we're going to just go through a few cases and then I will let Logan take over. Okay, so can anyone go through this ECG systematically? So go through everything we've gone through. So starting with name, age of the patient. I think because of time, I think I'll just give you the answers. Let's see if anyone's okay. Someone has said rate of 84. Good. So that's fine. So we'll go through rate. So we don't have a rhythm strip here. So we have to use the number of large complexes. So I go to lead 2. 1, 2. Okay, so starting systematically, I've already made a mistake. I need the patient's name, date of birth, time of ECG, a bit of background history, but we don't have any of that. The paper speed should be here at the bottom as well. But I know that this is a 25 millimeters per second paper speed. This is 1, 2, 3, about 3.75 big squares. So your rate is between 60 and 100. So it's a normal rate. That's all we need to know. Then are the PR intervals constant? They look pretty constant. Yep. Is there a P wave before every QRS complex? Yep, there is. What is the PR interval? So 1, 2, 3, 4, 5. So it's about 4.5. So that's normal. The ST segments look normal, looking at the J point. And then just looking at T wave morphology also looks normal. T waves all look the same. T wave is negative in AVR, a bit biphasic in B1 and upright in all other leads. So good. So in lead 3, it's also biphasic, but that's fine, like I said before. And then in lead, okay. Okay, so this is actually a normal ECG for all of those wondering. I just lost my page. The rate is about 85. There's a regular axis. So if we look at the most equiphasic lead, would be lead 3. an ABR, and then it's mostly negative. So if you want to just go back to, so you guys can see, it's mostly negative. The perpendicular one was AVR, but it's mostly negative, so going away, so it's a normal axis. Okay, and then QRS duration is less than 3 small squares, so normal QRS. ST look fine, and the QTC interval. So I like to look at it in lead 2. So you'd measure the QT interval, and then take that and use your Bezet's formula to calculate the corrected QTC. But looking at this QT, just calculating the number of squares between the Q and the T, it's less than 440. So that's fine. Okay, so then this ECG, I think we'll just go through 2 and then we'll let Logan take over. Or do you guys want to switch over onto ABGs, and then if there's time left over, we can go through this at the end? Is that fine? I think I'll just go through hypertrophy quickly. So for left ventricular hypertrophy, it's quite important because a lot of patients come in and they have hypertension, and then you can see LVH on the ECG. There are 2 different criteria you can use, the Sokolow-Leon criteria or the Cornell voltage criteria. I like the first one. It's just a preference. So you basically look at the R wave in V5 or the R wave in V6, and you add it to the S wave in V1 or the S wave in V2. And if it's more than 35 millimeters, it indicates LVH. Or if the R wave in AVL is more than 11 millimeters, this can also indicate LVH. So this is just depicting what happens. So when the left ventricle is thickened, then you can imagine there's a greater vector going in the correct direction. So then the ECG looks normal. The ECG trace looks the same as it should in V1 or V2. It's just that the S wave is much deeper. But in right ventricular hypertrophy, the vector is now going in the opposite direction. So you get some changes. And here's where you can get an RSR pattern similar to right bundle branch block. So this is what I was talking about before. Little r, big S, big R, because the big S and R are the normal, the small r and the big S are what you would normally have, your normal R and S wave. But then there's also an additional upward deflection. And then right ventricular hypertrophy is when there's generally right axis deviation of more than 110 degrees, a dominant R wave in V1. So see here. So normally the R wave is small in V1, but here it's really big. A dominant S wave in V5. So remember here you're starting to see it. You should normally see a transition where the S wave gets smaller, but here you're seeing a dominant dominant S wave in V5 or V6. And then the QRS duration is generally less than 120 milliseconds. So is this LVH or RVH, and why? So this is LVH, and why? It's because if you look at the S wave in V2, it's really deep. If you calculate and add all this up and add it to the R wave in V6, which is this one, you will get an answer of more than 35 millimeters. So add this R wave, right to the bottom. And then this deep S wave, which goes right there, you'll get more than 35. And then just all of you guys need to somehow memorize this, just the territories of where infarcts can happen, and the corresponding arterial zones, basically. And this is just showing an hyperacute anterior septal STEMI. I'm not going to go through the interesting conditions. I think we'll save that for, this is just showing slurred S wave, which is indicating Wolff Parkinson White. So slurred upstroke of the QRS complex, also called a delta wave. QRS complex is wide, and there's a short PR interval. So there's an accessory pathway, which is causing re-entry. Okay, so finally, please practice, try and practice as much as possible and be systematic, go through all the steps and you should be fine. And then some good resources, Life in the Fast Lane and Oxford Medical Education. Sorry, Logan.
No problem at all. Thank you, Ursa. That was really good. That was very good. Hi, everyone. Yeah, my name's Logan. I am working in ED at the minute. So just to kind of get the ball rolling, I'm going to talk about arterial blood gases. What level of training are you guys at? Are you medical students? Are you doctors? Are you allied healthcare professionals? And has anyone in the chat ever done a ABG or a BBG before? So why is a med student, fifth year medical student? Veronica, have you done an ABG before? Yeah. ABG, yeah. Perfect. Perfect. Okay, brilliant. So I'm just going to go through why we actually do them. Behind the ABG, oh, just go back a second. Thank you. Behind this ABG strip here that should say what, so what they actually are and why we're doing them, how we're doing them, and then we'll go into a bit of interpretation. So we'll just go through the process, the reasons behind it, and then we'll have a few examples. So it should be finished in about 15 or 20 minutes. Okay, thanks, Joris. If you go to the next slide, please. Brilliant, thank you. So what is an ABG? So it's essentially an arterial blood sample, and we usually take them to have a look at the acidity levels of the blood, so the pH level. That is one of the primary things we look at. As well as this, we look at the oxygen, the carbon dioxide, we look at sort of the lactic acid or the lactate level as well. And there's lots of different other electrolytes that the ABG or BBG can provide, and it will give us an overall picture of sort of health of the patient that's in front of you. It's really useful testing for oxygen levels, and that will inform management. And it's also really good to manage and monitor patients, ensuring that they're not getting more sick, and then hopefully they will be getting better with further monitoring. So how do we do an ABG? So usually, hopefully everyone's at least seen one before. They can be quite a daunting thing. I do remember the first time I did one. You get a pre-packaged syringe with an ABG needle in it. Usually, you'll have a syringe, a needle, and a little cap, which is usually the color green in color. You need an alcohol swab, some gauze, a bit of micropore tape, and you need gloves. So basically, you want to introduce yourself like you would any OSCE, consent the patient, explain the reasonings behind the procedure, and just explain it's slightly different to a normal blood test because it can sting quite a bit, and it can be quite painful. There is an option to use local anesthetics. So in A&E that Eurus and I worked at, they're a big advocate of using local anesthetic. But if the patients, that could be appropriate in an OSCE setting, but in practice, it's sometimes not the easiest thing to do because you need the ABG quite quickly. So faffing with some local anesthetic can just prolong or kind of delay the ABG result. So if you go on to the next slide, thank you. Really important, after you have consented the patient, explained the procedure, you essentially have to check for collateral circulation to the hand. And we do this by using Allen's test. You have to usually do this in an OSCE, or at least show that you're understanding about doing this, because it will get you points and will hopefully make you pass the OSCE. So you want to palpate both the radial and the ulnar arteries of whatever hand you want to use, and you want to occlude both arteries for a couple of seconds. And after a couple of seconds, the circulation, the hand will become a bit paler, and once you've done that, you release either the ulnar or the radial side, doesn't really matter which, but you keep one side occluded. But what you want to see is capillary filling after you've unoccluded one side. So if the hand remains pale or cold, then you shouldn't really use that hand, because that would suggest that you don't have adequate perfusion in that hand. You can get complications such as ischemia, fistulas, and that can be quite nasty for the patient. And yeah, it's really important that you do that prior to this procedure and document your findings. So Stephen's asked, turn red within how many seconds? So a couple of seconds, Stephen. So as soon as you let go of one side, you should get circulation back within 3-4 seconds. And then you want to position the patient. So depending on what side you've got or you're going to take the sample from, you want to put the patient's hand on a pillow or a blanket or something like that. You want to hyperextend the hand, palpate usually for the radial pulse, and then whilst holding the syringe, you want to advance up at 45 degrees. Really important to wipe it before and make sure that asepsis is observed as best as you can. You can be quite tentative at doing it. But I remember doing a few sort of in my F1 and kind of missing and being quite tentative. Just go for it in one movement. If you miss, you miss. You can always try again. But it's important to just, if you feel a pulse, just go for it. And usually the syringe will fill by itself. If you don't hit it the first time, don't panic. You can always try again. Sometimes you can go through the vessel, so you're through the vessel wall on the back, but you can just retract the syringe slightly. And once you've pierced the skin, that's usually the most painful part for the patient. So once you've pierced the skin, you can retract the syringe slightly or the needle slightly, keeping the needle under the skin and re-advance it towards the pulse that you're palpating. And then the next step, once you've got your sample, it should look like this. You got to run the gas machine. You got to run it on a machine, and usually they're found in the A&E. 9 times out of 10, the acute medical wards, ICU. If sometimes the gas machines don't work, it can be quite frustrating. Intensive care is your best bet. They usually have 1 or 2 machines up there. If the sample is arterial, so because this is an ABG talk, you have to put in the fraction of inspired oxygen. And what I mean by that is you have to put in how much oxygen the patient is on. So if we go on to the next slide, this is a really, really useful summary of the amount of oxygen delivered. Sorry, I've just got a question here. So fill the 2 mils if you can. That, yes, so you want to take at least 2 mils of sample, because what happens with the ABG machine, it will suck up a bit of the serum or the blood, and it can, if you don't have an adequate sample, it can be underfilled, and you'll have to do re-attend the ABG. So make sure that you have a well-filled syringe. That's a really good point. Fine. So this, I would take a photo of this. I would Google this picture. It's really, really useful. So if a patient is on, say, nasal cannula, they come in short of breath, and they're on 4 liters via their nasal specs. That means that they're getting 36% of oxygen. Okay. Conversely, if you look at the very bottom, if someone's really, really unwell and they're getting high flow oxygen, 15 liters a minute, that they're really, really unwell in ED, that's the equivalent of around 85% of oxygen being delivered to the patient. And that's particularly important. Sorry, Eurus, it's particularly important because once you're looking at your oxygen levels, your carbon dioxide levels, your pH on the ABG strip, it's very different if a patient's on 15 liters of oxygen as opposed to a patient is only on 1 or 2 liters of oxygen. So it's just really useful to have that in your mind's eye and run through the interpretation sort of steps. Thanks. You go on to the next one. Everyone should hopefully know roughly what the normal values on an ABG are. So pH 7.35 to 7.45. Really important to remember that anything outside that outside these values is abnormal. Okay, PaCO2, so the partial pressure of carbon dioxide, usually between 4.7 and 6. Oxygens between 9 and 13, and then you've got your bicarbonate between 22 and 28. This is for an ABG. For if you're taking a venous blood gas, so you don't need to go into an artery, there typically is a lower level of PaO2 and a higher level of PaCO2. It's quite difficult to interpret true oxygenation, true sort of hypercarbia or carbon dioxide levels in a VBG. So if you want to know the oxygen levels, the carbon dioxide levels, stick with an ABG. This equation I find really useful. So your body is basically keeping an equilibrium. And this equation, and hopefully everyone's seen it or is aware of it, it basically shows the relationship between carbon dioxide, water, carbonic acid, hydrogen ions, and bicarbonate. And in acidosis, so when the pH is lower than 7.35, that's usually a result of increased hydrogen ions, increased CO2, or a decrease in bicarbonate, and usually clinically a decrease in respiratory rate. So that's what the RR stands for. In alkalosis, usually hydrogen ions decrease because hydrogen ions are acid or sort of cations. So lower hydrogen ions results usually in an alkalosis, a decrease of CO2, an increase of respiratory rate, so that blows away the CO2 and decreases it, or an increase in bicarbonate. So someone's asking me, I forgot, if someone is in type 2 respiratory failure, which Venturi do you switch from? We'll speak about type 2 respiratory failure in about 2 or 3 slides. Is that okay? And we can talk about the non-rebreathe, the masks then. So if a patient is unwell, they usually try and compensate. So if they are acidotic, they will try and do something metabolically or physically in the respiratory rate response to try and compensate for this acidosis. Just go on to the next slide. Yes, thank you. Whenever I did my OSCEs, they usually gave us a little excerpt of sort of a patient, a clinical scenario, as it were. So you have to, ABGs are useful to look at, but it's in the context, similarly to ECG, so in the context of the entire patient. So I think this slide just summarizes some of the common conditions that will ultimately give you sort of a respiratory acidosis, so a retention of CO2, a decrease in pH, so things like infective exacerbations of COPD, asthma, bronchospasm, neuromuscular disorders such as myasthenia gravis, which will decreases the respiratory rate because they're not breathing as well as they should be, and patients become acidotic. In respiratory alkalosis, patients usually hyperventilate, so in PEs, acute pulmonary edema, and anemia and salicylate overdose. Metabolic acidosis, so lots of different causes for this. Is probably the most common sort of metabolic derangements of unwell patients. Lots of different underlying pathologies, so high lactate, sepsis, DKA, uremia, toxins, ethylene glycol. I saw a patient this week who had drank some antifreeze and they had a metabolic acidosis. Metabolic alkalosis, so a couple of different ways that you can become alkalotic. You can either lose hydrogen ions or you can have an excess of bicarb in the form of diuretics or vomiting. First thing we do is we look at that pH. So 7.35 to 7.45, anything below that is acidotic, anything above alkalotic. So that's the first step that you take and looking at the values of your ABG. Is the pH normal? Does the person have compensated alkalosis or acidosis? So that's where you look at the entire patient and come up with that. If the patient is acidotic, you can calculate the anion gap. That's a bit more complicated. I can certainly do it in a different talk, but it gives you a bit of sort of the underlying reason why they're acidotic. Yeah, go on to the next slide, Lisa.
Sorry, I've just lost the cursor, so
No, it's okay.
I'm just trying to figure out how to move to the next slide without having. Oh, okay.
Sure. And then you want to look at the carbon dioxide and the oxygen levels. So as we've said before, the carbon dioxide levels are between 4.5, 4.7 to 6. If CO2 increases, this is usually an increase of hydrogen ions and it lowers the pH and vice versa. So lower CO2 lowers the hydrogen ions and the pH rises. And if you look at and then we go on to look at the bicarb, the normal value of between 22 and 28. And bicarb is usually increased by a loss of hydrogen ions, so that could be an alkalosis, and decrease of bicarb usually due to increase in hydrogen ions, which is an acidosis. High sort of metabolic compensation in terms of bicarb changes, they usually take a couple of days. So it's not usually an acute change. So that's something really important to kind of remember whenever you're interpreting ABGs as well. Just talking about type 1 and type 2 respiratory failure, really useful to know. So type 1 respiratory failure is hypoxemia, so low oxygen without high CO2. And the treatment for that is usually CPAP, continuous positive airway pressure. And type 2 respiratory failure is low oxygen with high CO2, so hypoxemia with hypothermia. And the management is slightly different, so it's bi-level positive airway pressure, where pressure is set at 2 different levels to correct that. So in terms of which Venturi mask you switch on, so going back, if you just go back to the diagram, Yursa, if you could, of the oxygen flow devices, if you go back. I'll try and go back, can I?
Sorry, I'm just, let me just give you can
right.
try now?
I can try. It's not letting me. Could you just go back to the...
Yeah, see, I said hide pointer and now I don't know how to get it back. Does anyone have any smart idea?
Don't worry.
I think I found it. No.
Don't worry. If you Google that, I can get the picture of that diagram that we looked at earlier. It has all the Venturi colors next to the the amount of oxygen that's being delivered. So in CO2 or in COPD patients with sort of type 2 respiratory failure, you want oxygen sats between 88 and 92%. So it all depends on what and how their oxygen sats are at the time. So it completely depends on the patient. I was just wanting to go back and discuss the different values of metabolic acidosis and respiratory acidosis, if that's okay. If you can, that's fine. There's a good mnemonic called it's Rome. So if sorry.
Oh, you can try now. It says you controlling my screen.
Not letting me, unfortunately.
And it keeps showing all the answers. What is going on?
That's fine. That's fine. So there's a really good mnemonic called it's Rome. So respiratory opposite. So if the pH decreases, the CO2 goes up, and vice versa. So in respiratory conditions, if the pH goes up, so in respiratory alkalosis, the CO2 will decrease. And then metabolic equivalent. So that's the ME part of Rome. So if pH decreases, then the bicarbonate will decrease as well, and if the pH increases, the bicarbonate will increase as well. I can put that in the chat. Oh, brilliant! Thank you. This is it here. Yeah, if you go on to the next slide, Urissa, thank you. So typically in respiratory acidosis, the pH will decrease, CO2 will go up. Metabolic acidosis, the pH will decrease. Usually the CO2 will be equivocal and the bicarbonate will decrease with the pH. In metabolic alkalosis, the pH will go up with the bicarbonate going up. And in respiratory alkalosis, so remember respiratory opposite, so pH increases and the CO2 decreases. So that's a really useful little mnemonic at the bottom there. If you go on to the next slide then. So why don't we try there's 4 examples here, and then it's the end of the talk. So why don't we just have a quick chat through, if that's okay. So we've got a 65-year-old patient that presents with a cough and shortness of breath. The saturations are 87% on room air, so they're not on any oxygen. And these are their ABG results. So their pH 7.27. So mention in the chat, is it normal, acidotic, alkalotic? So we've got Y, we've got respiratory acidosis, hypoxia. Yeah, 0, well done. So, and the PaO2 is low with a high CO2. So we've got respiratory acidosis with high CO2. So does anyone remember what type of respiratory failure that is? Type 2, exactly. So it's type 2 respiratory failure without compensation because their SATs are low. So we haven't treated them yet. They've just come through the door. And how would you treat them? Can you remember? So in type 2 respiratory failure, it's usually BiPAP. CPAP is usually type 1. So it's really useful to remember as well. Cool. So if we go on to the next slide, please, Urissa. Yeah, perfect. Okay, so example 2. We've got a 72-year-old lifelong smoker, presents with a cough, and their saturations are 88% on room air. So pH is 7.4. Is that acidotic? Is it alkalotic? Is it normal? The PaO2 is 7.6. The PaCO2 is 7.3. And their bicarb is 32. So someone saying metabolic alkalosis forgot the normal value. So normal value of pH is between 7.35 and 7.45. So let's comment on the pH first. So metabolic alkalosis. So with a pH of 7.4, yeah, 0. So it's pH of 7.4, it's normal, okay? A PaO2 7.6, so less than 8, we would say they're slightly hypoxic, so that means that they've got low oxygen, right? PaCO2 7.3, is that normal or is that high? Or is that low? Can anyone remember? So PaCO2 of, yeah, so hypercapnia. So PaCO2 of 7.3, anything over 6 is high, okay? And the bicarbonate is 32. Normal bicarbonate is 22 to 28. So you would say that the bicarbonate is high, low, or normal. What would you say? High, exactly. Compensated respiratory acidosis, yeah, so we've got that exactly. So if a patient has a high CO2 but a normal pH, we're not concerned. Their saturations are normal for them because they have suspected COPD basically. So if you go on to the answer there, Larissa, that would be great. Thank you. So that's the example 1. And we go on to example 2. So go back a second. So it's chronic because their bicarbonate has elevated slightly. And remember, I mentioned that the bicarbonate takes a few days, a couple of days, a couple of weeks, a couple of months to kind of regulate and increase. So we can safely assume that this patient has probably been a bit acidotic before for quite a while, and they're compensating with their bicarb, but their pH level is normal. So we would keep their saturations 88 to 92. Okay, I hope everyone understands that. Going to example 3. Okay, so we've got a young patient that presents with an overdose of aspirin, and they're currently vomiting quite a lot, and they're feeling really unwell, and they have no oxygen requirement. So their pH is 7.54. Is that normal? Is it low, or is it high? So it's an alkalosis. Yeah, perfect. PaO2 is 7.8. Is that normal? So PaO2 is, so anything less than 8 is slightly, no, it's absolutely fine. Anything less than 8 is abnormal, so it's slightly low, PaCO2, is that normal, low, high? PaCO2 is kind of low normal, and their bicarbonate is 32, so it's slightly high as well. So it's basically does anyone remember what we were saying previously in the slide a couple of slides ago in terms of overdoses? What is aspirin? Stephen Toe's basically got it. It's a metabolic alkalosis because aspirin comes under salicylate. So it's an overdose of salicylate comes. So it's not a type 1 respiratory failure. And so the ABG results are, they're useful by themselves, but without the kind of clinical excerpt, it's difficult to interpret. So if we look at this, the patient has no oxygen requirements and they're on room air, so they don't need oxygen. So we don't think that this is a respiratory issue. We think that this is a metabolic issue because they've had an overdose of the tablet, basically. And usually overdoses of salicylate will give you a metabolic alkalosis. Cool. Next one, it's the last one, guys. CO2 is normal. Fine. It's meant to say example 4. So 46-year-old patient with renal failure presents just generally feeling rubbish. Currently SATs of 95%, so they are maintaining saturations on 4 liters of oxygen via nasal specs. So if we look at that little table that we saw earlier, that's an FiO2 or oxygen of 28%. So 7.34, is that low, normal, or high? So it's slightly low, isn't it? Yeah, exactly. PaO2, so I said kind of above 8 is compatible with life, basically, but it's still quite low. And then a PaCO2 is 3.8, so that's low. and the bicarbonate is 10. So does anyone want to have a guess? So we're saying that the pH is low. So Stephen's saying metabolic acidosis with partial respiratory compensation. Does anyone agree, disagree? What does partial mean? So, okay, so to basically what compensation means is that the patient, is doing something to try and compensate for their illness. So if they're acidotic, they're going to try and make themselves a bit alkalotic to make their pH normal. And if I can convince you, it's completely correct. So metabolic acidosis, so the patient is acidotic, and we are trying to treat that with oxygen because their oxygen's still low. So we're trying to get them back into a normal pH. We're getting there at 7.34, but we're not quite there yet, but it's a lot better than they were before. So the final answer is it's almost fully compensated metabolic acidosis because it's a low bicarb as well. Does that make sense? Okay, cool. So compensation basically means we're trying to get the patient back into a normal pH range. Okay. I'd definitely have a look at Life in the Fast Lane. Really good, as Eurissa mentioned. Almost a Doctor's